Welcome everyone to this month's discussion of an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It gives me great pleasure to welcome Dr. Madison Simons. Dr. Simons is a psychology postdoctoral fellow in the Division of Gastroenterology and Hepatology at Northwestern University Feinberg School of Medicine. Trained in nutritional psychology, her clinical and research interests include the precipitants and metabolic consequences of severe or prolonged dietary modification in patients with gastrointestinal conditions, as well as the role of symptom anxiety and hypervigilance in driving symptom burden. Today, she joins us to discuss her recent paper, Risk of Eating Disorders and Nutritional Deficiencies with Dietary Therapies for Irritable Bowel Syndrome, which is published in the current issue of Neurogastroenterology and Motility. Welcome, Dr. Simons, and thank you for joining us for this chat today.
Thank you so much for having me.
Great. So just to get some background for our listeners, can you put the current paper in perspective of the field, and what's the overall importance, and more importantly, what's the prevalence of these conditions in the population?
Yeah, so irritable bowel syndrome, according to the most recent Rome 4 criteria, affects just under 5% of the general population. That's according to worldwide prevalence estimates. But we know that a large number of patients with irritable bowel syndrome or gastrointestinal symptoms more generally modify their diet, upwards of 60% and above. And so this is a really important topic for patients and for providers who we know that food has some impact on symptoms in a lot of cases, but often this involves some trial and error. And so this is a really important topic and really frustrating one for patients to try to navigate on their own.
So can you give us some idea about why it was essential to write a review in this topic, also some background or common misconceptions or that questions that routinely come up to you, which probably prompted you to write this review in the first place?
Absolutely. The benefits of elimination diets for irritable bowel syndrome are well established. And so the intention of this review was not to call into question at all the benefits of these diets. But we found that as providers, there are many times when elimination diet led to more concerns than benefits. And so we wanted to highlight these risks to hopefully guide practitioners toward a more nuanced way of prescribing elimination diets that takes into account patients' resources for implementing the diet, their overall relationship with food, and their ability to maintain adequate nutritional intake despite these restrictions. And so the most common misconception that we come across in patients with IBS in particular is they might be told that a low FODMAP diet could be beneficial for their symptoms, but they're given very little information on what this actually looks like on the day-to-day practice. And so patients are often having to do their own research on it and then feel very overwhelmed when they see they need to eliminate large groups of foods. The question that often comes up is, what is there left for me to eat? And so this could go in a couple of directions. On one hand, patients may abandon the diet altogether, which has little risk to it, but may not improve their symptom experience. Or they could develop very rigid beliefs about the relationship between food and their symptoms and start to develop more problematic eating behaviors with medical consequences. And so that was the intention behind this review, is to start to get into what are those risks that could come up with an elimination diet? What should providers be paying attention to?
I'll just be a little bit more provocative here, and maybe that's not really a topic of this conversation, but why do we focus so much on elimination diets? I mean, I've always wondered why patients always feel like there is something wrong about the food that they eat, even though they've been eating that food since childhood, and they feel the need to eliminate as opposed to add something to the diet. So is this something which is inbuilt to us, that we always feel like we have to stop doing something rather than try to do something more?
That's a great question. And I think that's one of the directions that the field of nutrition and gastroenterology is going, is more toward these functional foods that are going to help to improve symptom experience. But as if we think back to even in childhood, if we were having a GI bug or something, we turn to very bland foods. We may stop eating for a period. And so as adults, when we start to have GI symptoms that flare, we might lose our appetite slightly. And it's a natural response for people to start modifying their diet, whether changing the nutrients themselves or going longer periods of time without eating.
Great, yeah. I just thought I'll bring it up, and of course, I think that's a bigger topic beyond this, but just for this review, what kind of methods did you use to come up with this review? And what was your thought process behind that?
Yeah, this review was really guided by the input of our entire team. So we have gastroenterologists, psychologists, and dietitians all involved in the team. And we sat down and talked about what are some of those factors that usually come up, and then dug into the literature around those factors separately. So this was more of a guided review based on what we have come across in clinical practice, and then brought it out in the literature to support what's being seen.
Great. And so, I mean, that's always helpful to have those kind of pragmatic reviews where people can have something tangible to take away. So what were your principal conclusions? And based on those conclusions, what would you say were your key take-home points if you want someone to remember, X number of things from that review? What are the things that you want them to remember without having to read the whole thing?
Yeah, I think most important thing we can have people keep in mind is that the purpose of an elimination diet is to improve somebody's quality of life. And so if the restrictions aren't contributing to symptom improvement, or they are so burdensome that they otherwise negatively impact quality of life, then the risks of that diet may be starting to outweigh the benefits. And we may want to look at alternative approaches to treatment. And so within this, it's important to keep in mind that there are medical risks with extreme or prolonged dietary restriction. And those main risks are nutrient deficiencies and development of disordered eating. And so on the front end, we want to encourage providers to be having those conversations with patients right off the bat. If the patient comes in and they're already engaging in pretty significant dietary restriction or changing their eating habits, then the prescription of an elimination diet is likely not the most appropriate first step for them. And we would encourage providers to involve dietitians or psychologists who are specifically trained in gastroenterology to support those patients. But if you do decide that an elimination diet is appropriate, and it can be for many patients, then the most important thing that you can do is to help set realistic expectations for the patients. The diet may help, or it may not. And the goal is to try to identify those food triggers and then restore you to the least restrictive diet possible. And often this comes by starting with a gentle elimination approach where we just try to eliminate those foods that are most likely to be triggers. Like in the case of a FODMAP diet, maybe it's the fructan category. So involving your team, dietitians, psychologists, and really talking with the patients about what is the purpose of this diet is what we would recommend.
Great. Just, in your practice, before you consider elimination diet, you screen patients in some way for eating disorders, or is there a chance that this becomes a way of validating an underlying disorder which the patient may or may not be aware of, or it exacerbates an underlying eating disorder?
Absolutely. So certainly if the patient has a history of an eating disorder, that can can predispose them to more risks once we start talking about elimination diets. But the concern in gastroenterology is what we call avoidant restrictive food intake disorder. And here you're going to see pretty generalized avoidance to foods with or without specific triggers, but people developing significant fear around eating that leads to vitamin deficiencies or dependence on supplemental nutrition. So those are things that we want to be watching out for. And in your initial conversation with patients, you'll start to hear from them if they're having a lot of fear around eating. And if that's the case, then you might want to be more concerned that an elimination diet, although it could be helpful, you want to bring in your other team members to support that, so the patient feels like they have tangible things to walk away with.
Great. So that, those were just my questions, but anything else that you want to add from your side, either about the review or about the area which you think impacts clinical practice beyond what we've already talked about?
I think just keeping in mind that quality of life is the most important thing when we're talking elimination diets, and often supplementing other treatments like behavioral intervention for IBS alongside dietitian intervention is going to produce the best outcome for patients. So many times they feel totally overwhelmed by the diet and are not sure what to do. And so giving them that coaching, having someone on their team really makes a big difference for them.
Great. So with that, I'd like to thank you, Dr. Madison, for this excellent paper and the review and assisting in the podcast this month. I'd also like to thank our listeners for tuning in, and I look forward to welcoming you again next month for another exciting article.
Thank you so much for having me.